So we have to put this in context, and the context is that we learned in the first demonstration project that teams can adapt this framework and use it to improve safety in their own environments, but they struggled a bit to make the transition from other ways of thinking about safety to this new framework, which really emphasizes not only past harm, but an appreciation of the reliability of the systems in which they're working, an understanding of how care is safe or not safe today, anticipation and preparedness for care tonight and tomorrow, and then putting together that entire picture to make it relevant for local units. And that insight that we had from the first time around led to some significant changes in the way in which we organized this session. So we're now spending more time with the teams, helping them make that sort of mental shift from previous ways of thinking about safety to this current, more encompassing approach. And we also, I think, spent more time in the sessions, the learning sessions, working with them around specific tools and opportunities to gain insight into the values that come out of each one of the dimensions of this new framework.
You see teams come in with kind of an idea of what this is going to be, and you hear them struggle a little bit with, needing to have a project or needing to apply it to something, and the uncomfortableness with the idea of just thinking about the framework, using the questions, talking to people about it seems kind of uncomfortable. And yet what I hear and see from teams is that when they do that, the experience they get back and the work with their teams and their staff is just so much more rich. So I think what I'm seeing a lot of is this idea of this is about how we think. This is about actually shifting from, that reactive more to we create safety, and how do we create safety through the way we talk, the way we see it, the way we act. So I think that's been really fascinating to see, is those ahas, those shifts, and I think it's because they're really encouraged to just do and sit with it and work through it, and then these ahas start to come. And those are more powerful than any, you heard one of the teams just this morning, I felt like I needed to get a PowerPoint together and take it out to people, and really had to hold herself back and just create discussion and really tap into the wisdom and the knowledge of the people who do the work every day. And that is so powerful.
The end result is this really amazing energy and commitment to this. And many people are saying that this is the thing that has really turned them around in terms of being able to now incorporate the safety work into their daily work on the unit, and working with their colleagues and having valuable and insightful conversations with their colleagues. So I think all that is really, really positive, and it shows that the framework has value. It's still a bit of a challenge to put into place, and that's something we have to continue to work on. But I think understanding this as not just a conceptual approach to safety, which is where it started, but a practical, applied way in which frontline staff can work with their teams to create an environment that supports safer care.
No matter what initiative you can create, safety lives at the point of care and service with patients and families and staff in an environment. And so what I feel the framework does is help them to think about that environment, think about their roles, and then come to, oh, maybe we need to work on this. Oh, this is a risk. And then those projects and those ideas and that change and implementation, tactical stuff comes. But I think what I'm seeing is that if you started with the tactical, I think what we're seeing is you would never get as far in really the sustainment and the culture change that I'm seeing in groups.
We started out in the safety world really worrying about past harm. And I think that was really important because it raised people's understanding about the magnitude of the safety issues. But it's insufficient because people don't go to work thinking about past incidents. They go to work thinking about the patients they're going to see today. And so that's part of the shift now, is we're putting safety into a much more relevant context for the staff on their units doing their daily jobs. And I think we still can build on that. We can create a broader sense of how units function and how units interact with other units. So we had an emergency department present this morning that talked about the importance of not only thinking about what's happening in their unit, but what's happening elsewhere in the hospital, and the way in which their work and the work of other units are interdependent.
Patient safety, a lot of it has been chasing after things that have happened before. You'll see things like policy or regulation and trying to fix what harm we've seen in the past. And I think what you're seeing now is this emergence of creating safety, that past harm is not the same as creating safe systems or creating safety. And I think in the past we've kind of connected it with, like, if you've got harm, you're not safe, or if we just can get rid of all that harm or focus on where we've had critical harm, we'll be safer. And I think that was a fallacy, really. I think, we're in a very complex environment, and that really being anticipating, reacting, responding, that doesn't come through a policy, or it doesn't come through even a checklist or things. It comes through that dynamics that happens in a team, the way people think, make sense of things. And I think that's a difference I'm seeing in how we're thinking about safety now. The other thing I think that's really shifted with the framework is we were focused a lot on insurance. So you hear a lot of people doing audits or being audited and those kind of things, where now it's about inquiry, and it's a bit more of, I was hearing this from my teams from the SHA, that it's no longer about let's just look at the outcome. It's like, okay, we implemented those processes, but are they actually able to follow the processes? Are staff actually able to do what we designed? And how do we understand whether our processes are reliable, not from a place of, making people feel bad about it, but to say why? Why are we not able to today deliver the meds in the way that we designed? And it's those inquiry or that curiosity that really pure problem solving that really helps us get to underlying what would make a process more reliable.
I'm really excited about this. I mean, we knew at the time that it was a steep slope to take this framework and put it into practice. And a lot of credit to Virginia and Alex and Anne, who've done a yeoman's job to get out, work with these teams on an ongoing basis, to have regular check-in phone calls, to ask questions about what are the issues, what are they doing. And the teams have come back and said this was one of the most critical parts of what we're doing, is to be able to reach out and to get some feedback on the things that aren't going as smoothly as we think, about engaging staff, about integrating these ways of thinking about safety into daily work. I think all that is a real credit to the coaches, and a real credit to the leaders supporting them in these environments, because this is a really tough time in healthcare, and we have leaders from across the country saying, this is really important for us. I mean, despite the financial pressures that we're facing, despite the emerging crises that we see today, this is an important initiative because it creates the groundwork for a deeper commitment of our staff to safety work and to being collaborative with their fellow staff.
I've been in Saskatchewan now 8 years, and one of the things that I've really appreciated when I first got there was that we started bringing patients to the table really early on. And again, not being that we'd figured out the right way to do it. We kind of sat with the uncomfortableness of it. But, in Saskatoon, we had a patient on the board, at the board table, at the Quality and Safety Committee. And so I think it's just become kind of the way we think about things. Again, it's like, okay, we have a team, so who's going to be the patient advisor, who's going to be, and so it's kind of become not just for the MSF, but for any initiative we do. That's one of the kind of key questions we ask, and I think it's in the working together, they really quickly, the teams, as you would have seen in New York, did really quickly recognize what she brings to that team. And it's not only the experience, what I appreciate, it's not only the experience of being a wife of a man who's been in long-term care and on that unit and experiencing what it was like, but she also she was a school teacher. She also has a history, she brings something, a different perspective, not just the personal, but her career. And that's been invaluable to the team as well. So I actually see that as a next level of how we think about patient family advisors. I think early on we thought about patient and family advisors as providing a perspective on what it's like for a patient. And I think we've learned over time that people bring engineering degrees and they bring, life experiences that may not be right specifically about how they interacted with the healthcare system. But if we can embrace all of that, it's just so much stronger.
To be a good coach, you have to, first of all, understand the framework and to understand how that needs to be applied in different circumstances. But you also have to have this sort of emotional empathy with the role and situation that these teams are facing. And I think we're really lucky that we have people who've had long experience and who can work effectively with these teams and to really relate the safety work to the struggles that people face on a daily basis. Many people are under a lot of pressure to increase the speed at which they're working with patients. And so we now need to give them the opportunity to incorporate these kind of safety frames into their daily work.
I think a great coach is somebody who is really curious and they want to help you get somewhere, but they almost become your thought partner or sounding board and help you uncover assumptions or things that you didn't know, like those kind of hidden things that your assumptions are often invisible to yourself, right? And we have a lot of assumptions in healthcare, personally, and then, in the system, we work from assumptions often. So I think a great coach both has enough content knowledge that can know where they want to get to. The journey of each person or each team is going to look different, so it's not necessarily somebody that feels there's a set path, but can reflect back, ask really good questions, make your assumptions visible, and help you have aha moments. I always say for my team, we're in the science of creating aha moments for people, and that's really because you create the conditions for people to have those epiphanies themselves. You can tell people to think differently, or you can, try to force it, but the real beauty comes when you can create the conditions. And that requires you to be curious yourself. It requires you to understand where the team's at and, to be really work from a place of respect and humility when you're with a team.
We've come a long way since the Canadian Adverse Events Study and then the development of the Canadian Patient Safety Institute, which has provided really foundational efforts to focus on safety. But this broadens the agenda and gives us an opportunity to re-engage with frontline staff. The key to safety is our ability to reach staff across the country in many different clinical environments and have them understand the challenges that they face in terms of the safety issues and their opportunity to respond to anticipate and to deal with those challenges. And that's what we're seeing in these teams. It's really encouraging. And one of the nice aspects of this is that these are teams from a whole range of different clinical environments, different provinces, small centers and large centers. So it says you can do this anywhere, right? This is a set of tools, a way of thinking that can be integrated into the clinical work of any unit.
I think early on in the framework, in the work, I think, again, I probably came in very similar to the team, thinking we would use this opportunity to solve a major issue in the organization, right? So in the first team that came in, I thought we were going to, solve the issue of, or at least focus on the peritoneal dialysis and transitioning to medical imaging from the OR. And that was both a quality, safety, piece, but also, cost effective. And so it made sense that we would want to do that safely and make sure we were monitoring. So I kind of had an idea of what this could do. And I think what my aha was that, again, what I started to see was individuals and the team start to look at every step of the process differently. So, we would start to see the radiologist go, you know what, I'm kind of noticing at the end of the day, these early signs that I'm maybe not as efficient or not as attentive, or I get interruptions. So right away they're thinking, maybe we need to move this to another point of the day so there's less risk for the patient. So I just started to see again, it still was trying to get to the same outcome, but it was really, again, about that ownership, that culture, those pieces. And so while the project was still important, it became a secondary outcome. And that was, I think, that was an aha for me, that this is how we could create that. I would have thought about, if we're going to create a project on creating a different culture, I might have thought of a different, or I might have, looked to organizational development to say, how are we going to do work on culture, or, let's create something on engagement. Well, this was engaging with people. People created engagement because it was stuff that was really important to them, and we created a space for them to think differently.
This is a way in which we engage our staff, because no staff member wants to be in an environment where they feel the care is not reaching the level that they want to deliver. So this is a way to really support staff. This is a very tough time to be working in healthcare, and I think it's important that we realize that our success rests on our ability to support and maintain the frontline teams who are delivering care on an ongoing basis.
There's got to be work at several levels of the system. I think as much as we know the power of doing this at the point of care, it is so easy with leadership changes and other things coming in for a senior level of the organization to go, oh, now we're going in this direction, right? So, and I think that what's so important is that we start to really wrestle with that. How does that lens, or how does the thinking of senior level, middle management, boards, as we talked about before, not because we think that they have to do the projects or do the work, but if they aren't thinking differently, they will impact the ability for the power that we've unleashed at the point of care. People look up, right? They get their direction by the questions that those that they report to ask. And if the board and the senior level aren't asking, or don't have a way of thinking in alignment with what we're trying to teach and coach and support the teams on, it'll make it hard for them to say. I still believe that they will be able to do it, but more things will come at them that are taking them in a different direction, and that's a huge risk. So I think we need to keep fanning the work with these teams. I think these team leaders will be great champions of other teams and help and support other teams to do that. But I also think we've got to do some work around what is that coaching and those aha experiences we have to create at that mid-level, senior level, board level. Those are some of my thoughts.
I'm most proud of the perseverance that we've seen in this effort. It's a steep slope. When we went to England and Scotland, we saw some good examples, but we were also told that many teams struggled with this. And in the course of the last 4 years, 3-4 years, we've really discovered that we can do it. We can do it in Canada with the resources and the teams that we have. And now the biggest question is, so how do we now move this to the next level?
We spend a lot of time at work. Staff spend a lot of time at work. And what I keep hearing is being involved in this work gives me meaning in my work every day. And it communicates to me that I have value in my day-to-day work. So, the person in the kitchen and others, and to me, that's core to safety, right? And so we talk a lot about patient safety, but you've got to, staff, physicians can't be present and focused on patient safety if they don't feel safe themselves. So to me, this bridges this idea of patient safety and staff safety and physician wellness. It is really, it really allows you to bring them all together and really create a culture of safety, or be able to create safety. I think we have this dichotomy that we often create where, OH&S is about staff safety. We have a group over here about patient safety. We have a group over here about quality improvement. And this really brings that all together.